So that's, you forgot.
I forgot. Yeah.
We both forgot. I didn't even think about that. So thank you.
Okay.
Um, but so yeah, so as I mentioned, so when you define a consensus, usually it could be, usually what has happened in the past and what other Delphis have done is that it's usually a consensus between experts, with at least 95% of the participants agreeing with the statement. So as I mentioned before, it's usually done on a scale from 1 to 5. So like 1 being I strongly disagree, 2 being I disagree, and then there's neutral, agree, and strongly agree. Usually if 95% of the experts strongly agree, or are pretty neutral towards the statement, that will be considered a consensus. And neutral is added to that because if they usually have no disagreement with it, but most of the other panelists agree with it, we will consider it to be consensus. And if on the other side, if 5% of the panelists or more than 5% of the panelists disagree with it, then it won't be considered consensus. And it will usually have to go through more rounds of revision and then rating again, and revision and rating to finalize what really is the problem with that statement. So next slide, please, Kimia. Wonderful. So with that structure, kind of a Delphi study, like what a Delphi study is, I want to talk about an example that we did, and I presented on this in the last workshop, but this is an international consensus statement that we did for the prevention, treatment, and management of youth with high-risk substance use and increased risk of overdose. So this is a paper that is currently in submission. So we currently have submitted it, and it's really a consensus of with 31 experts internationally that are working towards identifying the best practices and the best treatment settings and the best really recommendations for the prevention, treatment, and management of high-risk substances among youth. So this would be a similar project to do a Delphi study, and we want to reach an international consensus, but not necessarily among youth and high-risk substance. We would want, in this case, to look at healthcare factors and system level factors. So I'll just give an example. Perfect. So an example of some consensus statements that we achieved with this youth one, for instance, is that it is important to discuss overdose in an open and direct way within a harm reduction network framework. Youth who intend to use or youth who use drugs should have access to a spectrum of youth-friendly harm reduction services and be encouraged to use them. That's an example of a statement that was reached by consensus by the expert panel with the other project, with the other Delphi study. And so this is something that would be has the backing of experts in the field and is something that is important to discuss when we're talking about, in this case, harm reduction services, prevention, education for youth, and harm reduction. For instance, another important, really important one for this topic among youth is that for opioid dependence, evidence-based medication treatments, including opiate agonist treatment, are recommended as the first-line intervention. And this is particularly important because in youth, youth aren't generally provided pharmacotherapy as their first-line intervention. And in this case, the experts in the field have agreed that that should be recommended as their first line, as it is for adults, actually. So that's just an example of these statements that reach consensus with the several rounds of rating among with the other project. And you can go to the next slide. And you can just skip that one. We don't need to give another example. With this, I'm going to give an example of something that did not reach consensus, or like what happens when something is disagreed upon. So if you can just show the statement. Yeah, perfect. So this is one of the statements. So this was created in the first round of rating. So this was created at the very start of the project. And the statement goes as follows: the overarching goal of treatment is abstinence. However, controlled use or medication management may be more easily conceivable for some. Regardless, goals should be monitored and evaluated based on experience in treatment. So this statement did not reach consensus in the first round of rating. And so what happens is that we asked panelists, like, what is wrong with this statement? Like, what don't you like about this statement? What words would you change for you to agree with a statement of this value? And so one of the comments from the panelists was, and you can click the next one. What one of the panelists said is that I strongly disagree that abstinence is the overarching goal of treatment goal. A self-determined life without impairment through substance use is preferred as a goal. Abstinence in itself does not necessarily mean a person is doing well. That's a very valid argument. Like, that's totally valid. And that was reflected from other panelists as well, said the exact same thing. They said abstinence in and of itself is not necessarily the end goal. So this was revised with different rounds of rating, with different comments, and we were able to work through with all of the panelists something that they agreed upon. And so it's hard to see. That's my fault. I didn't make this slide easily readable, but it's the orange box above the two yellow boxes. So it starts with the objectives in treating youth. And so, yeah, thank you, Kimia, with your arrow. So the revised statement now, as it stands, is that the objectives in treating youth with high-risk substance use are to reduce harm and mortality, prevent interference in adolescent development and substance-related impairment, and promote resilience and positive youth development. So that's the process by which we were able to come to this agreement, this conclusion that the first statement was not good and had to be revised. And through different rounds of rating, we were able to, and discussions, we were able to figure out, okay, what is the problem? What is a better statement that we can all agree upon that is of consensus, right? And so that's the final statement that we came up with. So I've been rambling a lot about this different consensus statement that we are talking about, because I just wanted to provide an example of what we're looking to do with this project. So this is something that is similar to it in that we're going to be trying to reach consensus with panelists and experts. The topic will be the same. So yeah, perfect. So the Delphi study is, the point would be to obtain a consensus statement on addressing the opioid overdose crisis effectively to reduce mortality on a system level. So far, where we are is that we've built a questionnaire from a literature review and from expert opinions. And we've shared the semi-structured questionnaire with the panelists. And we're currently collecting responses to create new statements. And at this point in the project, so we've created the semi-structured questionnaire at the start. So we're in that idea generation phase. We're at the very start of the process. We're trying to create statements. We're trying to see what should be included in the final revisions. And this is why this workshop is so important, and why we really want your feedback on it, is that we want to know, what is there something that we missed that, so in the next couple of slides, and Kimia might talk about this more, we're going to talk about the domains and what we've included in the Delphi process so far. And we want your feedback because we want to know, okay, is there anything that should be of priority from the things that we mentioned? Is there something that we missed that should definitely be included? And so your feedback would be very appreciated with that kind of stuff. And I think that we would love your feedback with regards to the process, and to discuss some of the questions that we'll be asking the experts as well. So it's a good opportunity to provide questions that can be asked to experts as well. So Kimia, I'll pass it back to you. And yeah, then we can have a discussion a bit later.
Thank you, Jean. That was very thorough. I do believe there's something in the chat, if you don't mind checking that, if it's a question. I did want to stop at this point to see if anyone has any questions about the Delphi process before we move on to the next part of the presentation, or any other questions.
Yeah, it's a good place to stop. If anything that we said so far does not make sense, or if there's a confusion with regards to the entire process. I don't see any comments in the chat, Kimia, but I'm going to take a look at it. So I'll be going over it. So please, if you have any comments or questions, do put it in the chat.
All right, great. Yeah, so as Jean mentioned, right now we are, I'm sorry if that was loud. Right now we are at the process of, we're revising our initial questionnaire to send out to panelists. And one of the things that I would actually ask everyone here is, if you are interested in becoming a panelist, and you know, you believe that your kind of experiences in the field, you would like to contribute that as a panelist, I have my contact information at the end of the slide. So please feel free to email me and let us know, because we are still looking for panelists as well. So we would love your input in that way. All right. So here are our study domains. So I will go through this, and this is the part where we will really start the discussion. So the pace of the presentation is going to get a little slower, and I'm going to stop after every slide to discuss things. So right now we have, I don't even know how many this is, but I'm going to say we have this many domains in our study, and I'm going to go over each of them. We are going to go over it together, discuss what are some points that are included under it, see what we are missing, and what are some questions that you have for the panelists so that we can include that in our survey. Right, so our first domain is determining a target and high-risk populations. So as I mentioned, in the background, one of the biggest aspects of responding as a system is to understand which populations are high risk and which populations we need to address within our systems of care. Right now, we have this list included for the populations that we believe are at risk, but we would like to know your opinion of which of these populations you believe should be prioritized and you think are at highest risk, and if we are missing any populations that you believe should be included. So I will go to the next slide. Unfortunately, I did include some polls on Whova, but Whova has a limit of 5 polls and we have way more. So we are going to ignore Whova and do this the old style way. So I have the question up here, which of these populations should be targeted by the system to address the overdose crisis? And as I mentioned, we believe all of these are important, but we want to know which ones you think are most important or a priority. So, if people want to type in their answer in the chat or unmute and let us know what they think, please go ahead and do so. I'm going to stop right now and give everyone a chance.
Also, add any populations that may be missing that you think are super, super important that we haven't mentioned already. That's just something else.
Ask that after so we can get the A, B's.
Gotcha.
Yeah.
Gotcha. Okay.
And if it's easier to just talk about it, I welcome you to unmute yourself and just have a discussion. That's totally fine.
Hi, it's Karen from probation in Ontario. I would say C is very important.
Okay, could you elaborate a bit on why?
Or maybe elaborate why or what kind of services that patients after incarceration specifically need that would be really useful in better addressing their needs.
Well, I think it would be the discharge planning.
Yeah.
In the youth ministry in Ontario, we spend a lot of focus on discharge planning. And we can access funding for supporting reintegration.
Yeah.
Having said that, there's a lot more youth in detention and a lot more youth being held in court cells. And then young adults, after they're incarcerated, it's because they come back to the same environment. So some immediate support for reintegration, even with, let's say, the best exhaustive reintegration plan that you've ever had for somebody, it's more like the housing first approach, right? So that's the highest risk of use. They're back in the same scenario that they just left. They need supports. They need a peer support. They need addiction support right away for like the first 2 days. It's just like when somebody moves into a new housing, right? And they've experienced homelessness in the past.
Totally.
Yeah, thank you. I agree with that.
It's also important, like rates of overdose are so much higher right after incarceration. I forget what the number is, but it's like within the 2 weeks later after overdose, it's like multifactorial, like higher, and that's super, super important with that kind of stuff. And that's exactly like along the same lines what you were mentioning, Karen.
Mm-hmm. And then in terms of youth, I'm not sure that it's the naive user. I read on the poster board display, there was a poster about why students in university use opioids, and most of it isn't because of their drug history or their path of drug use. It's they were given opioids after a surgery and they weren't told how to get rid of the meds. And so then those meds lay around and a roommate would get them or they would abuse them later. So it's not really exploratory. It's like a brand new user without the support of a doctor telling them what to do, what to expect, that kind of thing.
That's a really good point. Then it might make more sense to separate some of these populations in the Delphi then.
Yeah, and then I don't want to minimize E either with Indigenous populations. I mean, you can just stop right there because of the history of trauma.
Mm-hmm. Absolutely. Yeah. So
you might want to put without
the limited no access to treatment. Absolutely.
Mm-hmm.
Yeah, no, it's true. And with regards to the youth, like with that kind of stuff, like, I mean, youth need prevention, early intervention programs and systems. And in Australia and very much in Germany, they have a lot of school-based curriculum courses that teach them about the harms of drug use, not necessarily telling them not to, just letting them know, like, like they're giving them all the information that they need to make their own informed decision. And then also giving them resources that if they make a decision, or if there are opioids lying around and they want to understand what the risks are, then they have the resources to access those. And I think that it would be good to, I agree, maybe remove the naive users aspect of it and just have, I think youth in general, in and of itself, would be which would be a good targeted population to address. And then the Indigenous populations, obviously, the limited no access to treatment is relevant, but it's more generally just intergenerational trauma and existing trauma is really the most important part.
But we heard Gabriel Maté say today that those students that need to hear those messages aren't listening because they don't feel safe.
Mm-hmm.
So youth who have been disenfranchised from school, who have developed a genuine dislike for school, marginalized by their school community and those school policies, plus those youth who are precariously housed, and those youth who haven't had treatment for trauma, who don't have an adult in their life that they trust.
Yeah, absolutely.
So residential care, in Ontario's Children's Aid Services, any protective services would be a good target.
Wonderful.
Great, thank you. Does anyone have any ideas for any populations that might be missing? So I think one thing that just came up might be people experiencing homelessness. I think is a big one that we are missing at the moment. So that is one that I will add for sure. But are there any other populations that come to mind that in your experience you think? Any other populations that come to mind that in your experience you think?
Hi, this is Kathy. I have a background in substance use and mental health, as I put in the chat. And so my experience working in an inpatient community settings as well is what I found is that it seems like I can't comment about populations that are missing. I think every population you have listed there is so important. But on a systems level, what I often find is that there are some great services out there that are trying to fill the gaps, to be the system navigators, the support. But oftentimes it comes down to the money not being there, which translates into then not enough workers that are out there to do the job. So that was just a comment.
Right. Yeah, like we know what the specific target populations are, but there's not enough outreach or services that are available for those, or resources that are available for those populations. Even though we know which ones they are, and there are things in place, we just need more people or more capacity to be able to reach them, or be in their realm of opportunities.
Yeah, definitely. And I was going to touch on this a little later as well, because we do have this coming up in a different domain, but some country, the European countries especially that are doing well with regards to overdose, a lot of them have, both high capacity and accessibility to treatment, but also very good coverage. So, it's that they have the funding both for research and also to provide timely treatment, which is definitely one thing that I think we're missing here, both in Canada and in the United States. All right, wonderful. So I'm going to move on to the next domain. Thank you, everyone, for the great thoughts. So the next domain, we wanted to look at critical sorry, it's like random sounds. We want to look at critical system level risk factors, and these are a lot more broad, but with regards to kind of use in general. So what, on a system level, what do we think are mostly contributing to risk of overdose in terms of substance use? And as you can see here, we have a variety of different kind of aspects that we have looked at. So we have, changes in availability of drug supplies, as well as contamination of drug supplies, different routes of administration that are used in the population, as well as our emergency responses, our accessibility to treatment services, treatment satisfaction and retention. So all of these, we believe, are definitely contributing to increasing risk factors for overdose. So again, I have kind of this poll here to see which ones you think are most significant, and what are some other risk factors that you think we are missing that should be addressed? Also, Jean, do you mind checking Huva as well?
Yeah, I got eyes on both.
Yeah, great.
So does anyone have any thoughts or ideas as to how significant, for instance, like the emergency response to overdose on a system level as a risk factor, how it can impact overdose or accessibility to treatment services? I know that there is a lot of, like Austria, for instance, has a lot of data that is collected for their opiate agonist treatment system, less so in BC and in Canada and North America in general. And I was wondering if anyone thinks how significant that would be, or for instance, like drug supplies. I think in Netherlands, they have a lot of, when they test drugs, they also keep track of how much fentanyl there is inside and what is contaminated. And they make sure to have that known so that people are aware of what is in the drug supply at that moment. So I was wondering if anyone has any thoughts on that, or any of these topics are up for discussion, really. And yeah.
I think maybe I'll make a comment on the drug supply, which is something that came up in our previous workshop. So a lot of participants were saying how there seems to be, so there was an increase in overdose rates starting around 2013, and it really peaked around 2015, 2016. And a lot of that was attributed to contamination of the supplies with fentanyl. And a lot of participants were saying how right now with the whole COVID situation, a lot of supplies are becoming domestic, and they're being made within kind of the country itself, and that itself seems to be kind of contributing to a potential fourth wave that is kind of changing the supply that people are getting. There was some discussion on an increased use of stimulants, but oftentimes these stimulants are kind of contaminated with fentanyl as well. But people that are using them don't necessarily know. So they think that they're getting stimulants, but a lot of times it's a mix of uppers and downers together that they're getting. So that, I think, was really interesting, and I definitely think is a contributor to overdose, not just because of the opioid in it, but also because we currently don't have any set in stone treatment for stimulant use either. So if that's rising and it's laced with fentanyl, then I think it's definitely a big concern.
There was a question in the chat on what is a route of administration. And so that just generally refers to how a substance is used. So it can be inhaled, it can be injected, snorted. So these are just different ways of using it, and they often have different risks to overdose, injection being the most risky route of administration. And keeping track of that is an important thing, and we've seen it in the past as well. So when fentanyl was first making its appearance on the drug market, it was so strong that people started inhaling it, so that it is less of a risk factor for overdose. And so that was some of the transitions or the route of administrations that were happening then. And now it's like still 40% of overdoses, I think. Fact check me on that, but I think that like a lot of overdoses are still due to inhalation, just because it's so potent. But that is an example of how route of administration changed over time and is a risk factor for overdose. So just to answer that question in the chat.
And just to add to that, the recent harm reduction client survey for BC that was done in 2019, they found that there is a rising number of people who are choosing to smoke opioids rather than inject them. What was interesting was, and I was having a discussion about this with my supervisors, is that we don't know if that choice is because like it might be to avoid kind of a risk of overdose. It could also be that because stimulant use is rising and a lot of people smoke methamphetamines, it might be that it's just easier to smoke the opioid as well instead of, you know, using multiple routes of administration. So that's also something else to keep in mind, is that there's just so many different factors going into how a person chooses to use the substances, and we just don't know at this point what is really at play here. So yeah, I just thought that was an interesting point to mention as well.
Maybe we can go to the next domain.
Yeah, with the next one. All right, so after this, the next kind of big system component, I think that everyone agrees with, is our healthcare systems. You know, this comprises of our different treatment programs, the treatment options, all of these things that we have available. So I have here a list of the ones that kind of stand out the most, that different systems have kind of used as measures to prevent overdose. But we were kind of wondering which ones you think have been the most effective and which ones you think will continue to be the most effective in your opinion. So like we know, BC has taken a big harm reduction approach with naloxone kits and a lot of different sites. And I believe in our last workshop, there was discussion that Ontario is also opening up a few more sites as well. So this is definitely a big thing in Canada. Integration of psychosocial treatments, we're seeing this less, but it is some programs are trying to at least encourage that, even if it's not happening in practice. And then you know, in terms of treatment provision, there's multiple different ways to provide that treatment. It could be a part of the primary care system. Individuals could have access to medications through pharmacies, and there was introduction of safe supplies earlier in the COVID as well. And then you know, having availability of opioid agonist treatment or abstinence-based programs. Again, like having that choice of getting either treatment, as well as online resources. So Canada's also really kind of taking the e-mental health approach, and Dr. Kraus, I think, is one of the leaders in the field. So, you know, kind of thinking of which of these approaches could be most beneficial in addressing the overdose crisis, in your opinion. I'm very curious about this one, actually.
Hi, it's Karen again. When you say integration of psychosocial treatments, is that where trauma counseling would be?
Yeah, like providing, so alongside, for example, opioid agonist treatment, providing that counseling and psychosocial support to the patient instead of just the medication and pharmaceutical aspect of treatment, if that makes sense.
Is there a way to include the word trauma, given the messages from the keynote speakers today?
Certainly. Yeah, that's definitely a good point to make. That, you know, even though it should be explicitly written, right? It's something that is so important that it should definitely just be there in the phrasing, even if it's because it just might be misconceived, or just not thought it's there, but it should definitely be there. I agree with you, Karen. Yeah.
And we do have trauma kind of coming up specifically in the next domain, which focuses on psychosocial treatments. But it might be like good to add this as an example here as well. I think that's a good idea. Yeah.
Hi, sorry, this is Emma. Just wondering if, and it may have been getting at the same. Hi, sorry, this is Emma. Just wondering if, and it may have been.
Go ahead. Sorry.
Sorry about that. So just wondering if this kind of ties into the trauma as well, I think. But maybe a specific mention about wraparound services and having collaborative kind of care. I'm not sure if this is where you see that fitting in, but just yeah, it's maybe emphasizing that these aren't provided in isolation, but how do we emphasize that integrated collaborative wraparound approach?
Like transition and seamless transition, and you know, like you don't need one to not do the other, right? It's not exclusive. They can all be working together simultaneously. And I think that the nature of this question, I agree, it looks like we're splitting them up. Like that's not our intention. We're just trying to determine what should be prioritized. But in the end, clinically and even throughout, these should all be available at all times. Right.
Yeah, and in the Delphi itself, like Jean mentioned earlier, it will be more like a Likert scale of to what extent you agree with each of these options. I just, due to the interest of time, I was, I've kind of made it more of a multiple choice option, but definitely, all of these should be included together.
Mm-hmm.
Sure.
Yeah, it's a good reminder, Emma. It's definitely something that should be mentioned.
Yeah, for sure.
Yeah. It's a good reminder, Emma. It's definitely something that should be mentioned.
Hi, this is Kathy once again, and I would agree with the comments that everyone has been making. Going back to an organization in Mississauga that I worked with, it was really the wraparound care with what you are speaking here in terms of all of the options that are listed. And you're right, it's hard to just tease these out because it really, in my experience, it is that wraparound that is most important. And I go back to, once again, oftentimes the agencies that are involved in this, there's just not enough workers, not enough money. So thank you. Thank you for the information.
Great, thank you.
Hello, it's Faiza. I just wanted to add, so there was a presentation in the morning from Switzerland, and they were talking about patient-centered. It should be like holistic patient-centered. I think you should maybe add that, so it's catered to the individual, looking at them.
Like individualized treatment approaches.
Yeah, I know that people call it patient-centered, I guess, but there's different languages. I think should be holistic if it's coming from, if you look at the medicine wheel, right, for First Nations communities, they use a holistic approach.
Yeah, and I think that ideally, like, it would be patient-centered in that maybe some patients prefer having more of harm reduction services and less of, say, psychosocial treatment. But then there are other patients that would prefer more family-based therapy, for instance, for youth or adolescents, a lot more family therapy and pharmacotherapy and less harm reduction or adult-centered services and that kind of stuff. And that plays to like the patient, the patient gives us their preference and their needs. And from that, we prioritize whatever services that they think is best for them. And I think that is also within that, there's like that seamless transition between all the different services. And I think that that's what is being reflected in the conversation right now.
Yeah, definitely. These are all very good points. All right, so in our next domain, we looked at the specific role of psychosocial interventions. I believe it was mentioned in the keynotes previously that, or maybe it was in the workshops, I'm not sure, but there's a lot of evidence on, psychosocial care and underlying mental health problems in people who use substances and the necessity to address these underlying issues. However, we're not seeing a lot of integration of that. So in this domain, what we were trying to do is kind of get the panelists thinking a bit more about what are the potential benefits of integrating psychosocial treatment into kind of the treatment programs available for addiction, and whether or not it should even be integrated. So should all pharmacotherapy interventions be provided with psychosocial interventions? So these are just kind of some of the potential improvements that can come from having psychosocial care. But yeah, I guess it's harder to pick which one's important for this one. So what I will ask is if you think there are other benefits of psychosocial care that should be included, or if there's one that you think is extremely important.
Is there, hi, it's Karen. Is there a, can you describe behavioral and risk management? Because I think quite often when we focus on behavioral management programs, they seem quite punitive. So I wonder, is that what you mean there? Or are we talking about managing risk, managing stress, managing decision-making when we're under stress?
Yeah, I think it's mostly the second one. So I think this one's mostly pointing to programs like, cognitive behavioral therapy, motivational interviewing, kind of ways to really sit and think about why certain patients are making certain decisions with regards to, substance use, or why they may be using substances, and how they can manage those stressors in ways other than kind of coping with substances. That's how I believe that point is being addressed, but maybe it needs to be more clear. I think.
Also with that behavioral and risk management, like for instance, I think that it's important that everyone is educated and knows that a risk using alone has an increased risk of overdose, and a behavioral change that might come with that is injecting with someone else, or having someone there, or going to a safe injection site. Obviously that touches on the need for safe injection sites and the need to have a social network available there for you. But those kinds of risks and then behaviors are tied together. We're not telling them what is best and what is worse, and we're not trying to change the entire behavior, but just educating them on what is risky, and then what are some easy ways to reduce that risk of overdose, and to really start the road to recovery.
Yeah, exactly.
Hi, this is Emma. Not sure if this one fits in here, but if psychosocial care includes things which might be more around housing and support around some basic needs as well, it would. Okay, so maybe even just improving wellness and decreasing risk in that way. Just wondering if maybe something around wellness might be included as one of the benefits.
Yeah, housing. I mean, all of that social support, housing, those are all tied within each other, and I think that that's important to also highlight. Yeah, you're right, Emma.
Yeah, the more we are discussing, I'm starting to wonder if we should add a domain on housing and social.
Just social services. Yeah.
Yeah, because I think that's the main domain that we're missing.
Because along those lines, it's also perinatal services for women of childbearing age, for instance. That's also a really important service, and that should be a care that is integrated into substance use treatment. Like comorbid conditions or those kinds of services, along with the housing one, are important ones to highlight.
Yeah. All right. Great. Yeah, we are definitely missing that domain.
Hi, it's Faiza, sorry. So just going back for the psychosocial care integration, the presenters from Switzerland were also talking, they had actually encompassed the housing, employment, all the social determinants of health within that umbrella. Yeah. So they were using it as psychosocial care integration. So I'm not sure if you necessarily need to create another domain, but it may fit within that.
Okay.
Right. Good point. Yeah, the psychosocial. Yeah, perfect.
Yeah.
And then in that would fit connections with others.
Yeah.
Definitely. And that definitely ties into kind of using alone or in isolation, which is a big factor for overdose. So that's a really good point. Okay. In the interest of time, I will go over one more domain, which I think is very important, and then wrap it up, but happy to answer any further questions. So the next one, which I'm very curious about your input, is the availability of treatment options and programs. So I have two questions for this one. The first one is, which programs do you think are kind of making the difference right now. And I think we kind of touched on this beforehand, so maybe I don't want to spend too much time on this, but this is the main question that I have is, this is one of the big system level differences that we are seeing across the countries having the overdose crisis and ones that are not, and that's having the choice of medication that the patient receives when they are in opioid agonist therapy. So I'm curious to know, how many people here agree that patients should have the choice of medication that they receive, and how many believe that some of these medications are maybe more harmful than others and should be not necessarily provided as a choice. Yeah, this is really something that I would like to have a discussion on. If anyone wants to unmute and contribute, this is an important one.
Or experiences, like the experiences that they from their clients or their patients with these medications specifically, or others if there are not on the list as well.
Yeah, like anything you've heard from the patients that you think.
Or others if there are not on the list as well.
This is Kathy again.
Yeah, like anything you've heard from the patient that you think.
Yes, this is Kathy again, and that's a great question, by the way, just because in the previous role where I was, I'm a registered social worker, and so working with my clients, going to their appointments at the OATC clinics, is that seeing this often where accompanying them and seeing their addiction doc and looking at the options, oftentimes the client really couldn't choose. It really came down to what the doc thought was better, and I think as well, the client often struggled with that and didn't seem to have a voice in the options. So I think this particular question is a really important one. I don't have sort of the answer, but I do think that the client or patient needs to have some voice in this decision making. Absolutely.
I think that touches on actually, like, I think that even answers the question of which of the following medication options do you think should be made available. And that's what I've heard clinically as well, is that some medication may work for some and may not work for others. And I think that having all of them available is really the answer. And then if they try one and whatever preference they want from history or what they've heard works better or not, and then if they try it and say for example buprenorphine or Suboxone doesn't work, they might want to try Acadian or methadone, and having the ability to say and voice their concern about what preference that they want to have for OAT is really important from a patient's perspective. And so thank you for that comment, Kathy. I totally agree with you. And I think that that's something that we should highlight with this particular question and with this like panel of experts as well.
Thank you. Okay, so we are running out of time, unfortunately, so I can't go through the other domains, which is really sad. But I will make these slides available on Whova if you're interested in having a look. I do want to go on the closing remarks slide, just so that, if you are interested in becoming a panelist for this study, please send me an email. We are currently looking for panelists, so feel free to do that. And yeah, I just, kind of bringing everything together. First of all, this was very helpful to us for the study, so thank you so much. We really appreciate your feedback on everything. But I think what really kind of everyone is saying together is that the main goal of the system seems to be integration and also providing support for the people who are using substances by giving them different options to get the care that they need. So a lot of you kind of mentioned how it's difficult to pick one that would be the best approach, because individualization and having that choice of treatment seems to be what works best. And I agree that I think that is one thing that we are missing in our system to a large extent. And it's one thing that we are seeing that is different between North America and a lot of European countries that are doing better, is that choice component. So yeah, Jean, do you have anything else to add?
No, that was good. I want to thank everyone for coming. That was a really wonderful discussion. Thank you for being so active. I hope you guys have also had a good conference. I realize this is the last workshop, and so I just want to thank everyone for coming. I hope you enjoyed the last, I think there's one more keynote and then the closing remarks. So I hope you're able to make it for that, and just want to thank everyone for their time and then coming to this workshop with us.
Yes, thank you so much, everyone.
Do you want to stop recording?